Hello, and welcome to Ask Dr. Dawn. The opinions expressed in this program are those of the speakers, and this is a program intended for education and entertainment. It should not be construed as a substitute for a medical consultation.
So let's start with the lead story tonight, a ready for prime time in-human study that is truly groundbreaking. A single infusion of a stem cell-based treatment may have cured 10 out of 12 people with the most severe form of type 1 diabetes. 1 year later, 10 of these patients no longer need insulin, and 2 other patients need much lower doses. The experimental treatment is called Zimislecel. I'm going to spell that, Zimislecel, and it's made by Vertex Pharmaceuticals of Boston. It involves stem cells that the scientists carefully prodded to turn into pancreatic islet cells. They took stem cells essentially and drove their differentiation. Pancreatic islet cells are they're your natural continuous glucose monitor, except they also make insulin. So while they measure the blood for glucose, and when the glucose starts to go up, they make insulin. Well, they infused these living cells into the patients, and the cells reached the liver where they took up residence. So they didn't go back to the pancreas, they went to the liver, plenty of room. This was just presented at the annual meeting of the American Diabetes Association, and it was published online by the New England Journal of Medicine. So the current issue, if you go to that, I don't know if there's a paywall for everyone. I've got a membership to that one, so I can't tell. Anyway, the idea that we might be able to treat diabetes is just amazing. Essentially, pancreatic cells that were from stem cells, these stem cells were then turned into pancreatic islet cells and given to patients. It could make people free of needing insulin. Now, hasn't been approved by the FDA, but the study is the fact that it has had this kind of success is really jaw-dropping. Now, they only studied it in a small population, and these are people who have very severe type 1 diabetes, which is essentially you lose all of your beta cells. It's an autoimmune disease, so you lose those pancreatic beta cells and you can't make insulin. And with absolutely no insulin, you die. Your cells cannot, glucose can't enter the cells, and there are cells that absolutely require glucose to get in. So without the insulin, you can't unlock the door. The glucose can't get in, and you die. We know that elevated blood sugar levels are very dangerous. They kind of fry the inside of the blood vessels. They damage the kidneys, they damage the eyes. But if people's levels fall too low, they can have seizures or pass out. And there's a subset of people who are the ones in this study who have a complication of type 1 diabetes called hypoglycemic unawareness. Now, normally, when your blood sugar drops, you feel shaky, you get sweaty, your heart beats quickly, and this is because your system is sensing this and putting out a bunch of adrenaline, because when you put out adrenaline, it causes glycogen in your muscles to be broken down and dumped into the bloodstream. So that's your fight or flight response, and it triggers when the blood sugar drops radically. By the way, this can also cause mood disorders, and one of the things that I do now for patients who have anxiety attacks is I throw one of those 2-week continuous glucose monitors on them, and I see if they have a drop in their blood sugar level before rapid drop. It doesn't even have to go below normal. It just has to drop quickly. And in people with a low threshold for this reaction, it'll set off an adrenaline response, which reads as a panic attack for these people. But people with hypoglycemic awareness don't do that. They just pass out or have seizures or die. And they don't feel it. They don't get that warning, and they don't get that response that's a rescue response. So they did this on, as I said, 12 people. patients in the study began to need less insulin in a few months. So those new cells took up residence in their body quite happily. And the hypoglycemia episodes, which are driven by the problem of giving accidentally too much insulin in these individuals, that after 3 months, 90 days. After 3 months, there were no more hypoglycemic episodes. And this was in people who were having them once or twice a week. So this is very promising, and we're a year out now. A few patients did have to stay on some insulin, but much less, and they aren't having those hypoglycemic episodes anymore because their blood sugar is more stabilized. But, and here's where this is a transitional but useful thing, the patients on the trial had to stay on drugs to prevent the immune system from destroying the new cells. Remember, I said stem cells, but not their stem cells. This treatment is really interesting backstory. It's the culmination of work that began more than 25 years ago when a Harvard researcher named Doug Melton vowed to find a cure for type 1 diabetes. His 6-month-old baby boy had developed the disease, and then so did his adolescent daughter. His passion to find a way to help them and other patients was unwavering, and after 20 years of painstaking, repetitive, and frustrating work by Dr. Melton, who fortunately had a PhD and a lab at Harvard, and his team of about 15 people, they found the right chemical cocktail to signal to the stem cells to turn into islet cells. Cost about $50 million on this research, and this is just an amazing, amazing thing. It was hard to recruit the 12 patients because they had very strict entry requirements. And some basically backed out when they learned that they would have to take immunosuppressive drugs for the rest of their life. Their immunosuppressive drugs are no picnic. For one thing, it increases the risk of infections. And over the long term, it can increase the risk of cancer because, hey, our immune system is the first line against cancer. We have a caller. I'm going to go straight to that caller, as is my usual policy. Hello, this is Dr. Dawn. Welcome to the program.
Hello, doctor. I have a point of curiosity relative to a friend of mine. His daughter has been diagnosed with malignant myeloma, with the primary tumor site being on the medial right leg. They've done 2 operations on that particular site. And they have gone into the mode now of they have just, as a follow-up, given her this drug called Keytruda.
Mm-hmm.
And what I looked at, it's a pretty intense drug as far as side effects and everything. And can you give me some sort of an idea on questions that might be asked of her treating doctor as to what determined his progress into using this drug on her?
Okay, well, first of all, I suspect that this is malignant melanoma, not myeloma.
Melanoma.
Yeah. It's easy to get the two confused. They sound alike, and it happens quite a bit. Now, Keytruda was originally developed for breast cancer, and it's a monoclonal antibody. It's an immunotherapy drug, and it targets a protein called the programmed death receptor on immune cells. And so this programmed death receptor is essentially hijacked by the melanoma cancer cells. And so they use it to essentially put the brakes on the immune response. So the immune cells die when they try to approach the cancer. It's kind of like an anti-immunity force field. So if you block that, then it allows the immune system to treat. Now, this drug, I believe, was the drug that Jimmy Carter got like a decade ago when he was initially, more than a decade now, he was diagnosed as having metastatic melanoma that went to the brain, and he actually was a clinical cure and had 10 years which in cancer is considered a cure, even if the cancer comes back after 10 years. So, there's our definitions of cured sometimes are a little funny in oncology, but we have to draw a line so we can do the research and close out the project and say, okay, it worked. Now, this is a heavy drug. It can cause a serious immune overreaction. So it's considered immunotherapy, and most of the reactions that happen are as a result of the immune system kind of going overboard and becoming overly aggressive. And so you get fevers and you get inflammation, very high levels of inflammation, which can lead to rashes and diarrhea and bone pain and lung inflammation and low thyroid hormone levels. And some of those problems can cause permanent damage to the organs, lungs, liver, but it's really most commonly used in a situation where the cancer has spread. So I'm not sure about what protocol this woman may be on an experimental protocol, what we call a clinical trial, to see whether you can avoid amputation, which might be have been on the table. I don't know this case, so I want to want to say that I am speaking very speculatively. But if the cancer is locally invasive to bone, then but hasn't spread to all the other organs, maybe that's a trial going on, right? But if it's spread to the other organs, this would be considered the new standard of care. From
what I understand, they did the first operation, and then they found that it had come back virtually in the same area, so they went in and, quote, scraped it, from what my friend tells me. I don't know.
No, that's right.
Yeah, and so is it just standard protocol to then go to the chemical?
Well, I can't. The standard protocol depends on something called the staging. And so what we don't know is we don't know her staging. Is it local recurrence only? Is there disease in the usual suspects, which would be the liver, the lung, the brain, because it likes the brain? And not knowing that, I would infer, if this was, say, 5 years ago, that she had metastatic cancer, and that was that. But and that would be the standard or the latest greatest. On the subject of cancer therapies, these biologicals coupled with our new technologies, which include everything from AIs telling us how to build proteins amino acid by amino acid and then spitting out the sequence of the DNA needed to grow the damn thing, and then taking that and using CRISPR to cut and paste it into cells. I have another story coming up on that. This program, things are moving so fast that it's really hard to know what to say about it. But I do think that we've got some real amazing things going on. And in terms of risk versus benefit, which is always a question you ask, this is a young person, right?
She's, I think she's in her late 20s.
That's a young person.
Yeah.
And so she's got 60 years to lose.
Right.
As opposed to, say, would you do this to, say, a 65-year-old with a heart condition? And maybe not. You'd look much more carefully because they've got maybe 10 years and you don't want to kill them. And their resilience is way lower. If they get that high fever, their heart's not going to handle it. Whereas a young woman can handle a temperature of 104. She can handle a heartbeat of 150 a minute for days, whereas that'll give an older person a heart attack. And so the odds are better even if the immune reaction is very strong. And that's what killed people during COVID, right? The overwhelming immune reaction was at least as deadly as the viral infection. Because
she had one of the doses, I guess, for the drug, and it just knocked her flat out. And so, how many doses is quote normal? Or you probably can't say normal.
I don't know. This is a real specialist question. You can look it up, and if you want more information, I would go to I would go to what's it called? Perplexity, which is one of the AI sites and tends to be a bit more scientific. And so, all AI things have to be read with a grain of salt. But if you say what is melanoma staging, and then find out from your friend the father what stage she is, and then you say what is the standard oncological therapy for melanoma stage such and such in a 20-year-old, a paper's gonna pop up, and you can throw Keytruda in as a keyword. There's probably other PD-1 agents. There's things called immune checkpoint inhibitors that act on a different on a different mechanism. There's this micro RNA stuff now that we're making that sort of turns off things that the cancers are making by erasing the transcribed DNA. Basically takes the RNA away, and we've just got this new toolbox, and we're going crazy with it. It's like what happened with the first antibiotics back in the 40s. So I hope I've helped. Anyway, it seems to me that if she had a real hard time with the drug, they'll give her a lower dose. That's usually what you do. And so you give, it's like, okay, that was too much. So you give less or give it less frequently. And that's sort of the strategy, or has been the strategy in general with chemotherapy drugs.
Okay. All right. Well, I appreciate your help, and thank you so much.
You're welcome, and thank you for the call.
Okay. Bye-bye.
Bye. Let's go to this email. This is from an anonymous emailer. Dear Dr. Dawn, I have osteoarthritis, and in the afternoon, if I'm hurting a bit and I sit down and rest for about an hour, I feel better and can get up and move around just fine. So my question is, why do I feel so bad in the morning after 8 hours of rest? And you're not alone, Anonymous. Many people have the worst arthritis pain after an overnight rest. New research from the, let's see, what school is this? RCSI School, University of Medicine and Health Sciences, and I don't know where you are. They've been looking at the body clock, chrono research, and they describe how immune cells, the macrophages, actually work differently at various times of the day. And this could pave the way for time-targeted treatments for inflammatory disease such as arthritis. I talked not very long ago about chronotherapy in the context of cancer and how fasting for 18 hours and then getting your chemotherapy in the afternoon was the sweet spot in terms of making that chemotherapy the most powerful. And we're talking about chemical chemotherapy here that poisons the physiology, not necessarily the immunotherapy, which is mostly beefing up the immune system rather than poisoning the physiology. Anyway, getting back to the macrophages, these are immune cells that are in your blood and in your skin, your mucous membranes, and they are kind of the first responders. They detect and respond to harmful substances. They then trigger inflammation that brings in the other white blood cells that are mainly in the lymph nodes and clinging to the walls of the blood vessels until they receive a chemical signal. So you can think of the macrophages as kind of the smoke detectors. Activation of an inflammasome, very important one called NLRP3, which is something that turns on the production of various RNA in the nucleus and then sends it out to the cytoplasm where it is sucked in by the ribosomes and they spit out like an extruder the protein, and the protein folds on itself and becomes an interleukin, an interferon, all sorts of other chemical signals that then carry messages throughout the immune system and call those cells to the site of the production where it's been revved up. So the macrophages' energy levels peak in the morning. And when macrophages think it's morning, their inflammasome activation of this NLRP3 is quicker and more robust. So early in the day, and this probably has evolutionary advantages, the immune system is heightened. We're awake. We're more likely to encounter environmental challenges like injuries. We're probably, in my case at least, still staggering around trying to make that first cup of coffee. But treating inflammatory diseases like arthritis, where overactive inflammasomes are a role, there might be a way to help block that, and the timing of the agents that you take, taking them such that they reach their peak blood level in the morning when you're likely to need them the most, could be an interesting strategy for those who are taking long-acting anti-inflammatories of any kind. And I think taking them at bedtime the night before, especially if you're on one of those 24-hour pills, that might make a lot of sense. So you're at least waking up with a level of the downstream prostaglandin suppression. So, interesting little tidbit there that was in my list of things to get to someday. And thank you, Anonymous, because you jumped it to the front of the line. We're going to go to Carrie Carrie didn't say where she's writing from, or he. Dear Dr. Don, please talk about food allergies and how to track or identify them. I've had irritated, watery, itchy eyes and a discharge on my eyelashes some mornings that I have to get off to open my eyes. First, several months ago, I thought it was allergies, including being allergic to my cat. Then I thought it could be inflammation causing the irritation and rash around my eyes. I now think it could be allergies to things in food I eat, and I'm going to watch and track what correlations there may be, but I would love to hear about this. I'm tired of itchy, irritated eyes. Well, Carrie, the first thing I would suggest is if you have a physician, go and have the physician use their ophthalmoscope, which is the magnifier thing they use to look in the back of your eyes, and focus on your eyelashes and see if you have little pimples along the base of your eyelashes, because the irritated eyes with the glued together stuff could be allergies, absolutely. But if you've got those little pimply looking things around the bottom of the eyelashes, you probably have blepharitis. And this is a bacterial infection, but it doesn't really infect the conjunctiva. So you get an irritated eye, but you don't necessarily get like the bright red eye of bacterial conjunctivitis, which usually sends most people off to their doctor when they have it. That being said, there are allergic eye drops, and I would suggest that they have antihistamines in them, and they're over the counter. I would suggest getting some of those and using them in one eye for a few days running and see if the eyes diverge in terms of their reaction, because that'll help you understand whether there's a histamine involved, which would be an IgE type allergy. I think it's unlikely. If you do have a food allergy that's doing this, then the best thing to do is to go on an elimination diet, which can look differently depending upon where you're starting. Most of us eat about 15 foods regularly, statistically speaking. And, we may eat a whole bunch of different versions of wheat, corn, and soy and think we're eating a bunch of different foods, but those are 3 foods. And when you talk about fruits and vegetables, again, people tend to get a little bit monotonous, spinach, green beans, and carrots or something like that, and you cycle through those. So you want to take those things that you're eating very frequently, more than once a week, and find a substitute. So find other vegetables, know how to cook them, and you basically take yourself off the usual suspects. And you'll need to do that for about 30 days. There are certain foods that are part of if you go elimination diet and you look that up online, there are certain foods that are on all of them, like, for example, wheat and dairy. And so wheat, dairy, corn, soy, peanuts, those are some basic, very, very high prevalence compounds in the American diet. And so they become more likely to cause this kind of allergy. I really have seen a lot of food allergy in my life, and without other skin manifestations, and without gastrointestinal manifestations or joint manifestations, it's not the first place I would go diagnostically on you. I would definitely be looking for some kind of local infestation. And you might have eyelid mites, which can cause an allergic reaction. And those are also something that you can see under magnification. So a visit to someone who's, an ophthalmologist or a primary care doctor who's actually got time to think, and that'd probably be the first place I go before putting my patient to the and doing the trick with the antihistamines, because if they don't make a difference, that again, that's kind of the last thing to do before actually going and getting this looked at. All right, we don't know if you use eye makeup. I'm assuming that you're smart enough that if you wear eye makeup, eyeliner, mascara, that you stopped using those for a couple of weeks to see if they were driving it, because topical agents are definitely a possibility here. And yeah, I think that's about all I can come up with for you, Carrie. So thanks very much for the email, and I hope I've been helpful. And we're moving through the toy box of new science advances using all of these great reprogramming tools that we have. This one is not yet ready for prime time, but it's pretty interesting twist on the CAR T-cell therapy. Now, that stands for chimeric antigen receptor therapy. And an antigen receptor is, among other things, what a T-cell, your thymus-derived immune cells, use to attack bacteria, attack cancers, and attack viruses. So in the case of CAR T-cell therapy, it's primarily have been used to treat blood cancers like leukemia, lymphoma, and multiple myeloma. And it's amazingly effective. A report just came out a couple of weeks ago in JAMA extolling a cure, at least in the cohort that they did. They had something like a 35 or 40% cure. I haven't actually read the article for my sins, but the treatment's available now for these diseases in the United States. You have to be able, and like the Keytruda that we were talking about earlier on the program, it's a hard therapy to take. And so if you're already very debilitated, you may not be a candidate because it's a lot to ask the system to survive. Another thing is if you have a high disease burden and you're late in your cancer and you failed multiple different kinds of chemo, so you're in kind of a rescue mode, that's the group that this study was using. These are the people who get into these kind of Hail Mary clinical trials. Well, it's no longer Hail Mary therapy. It's therapy, and it's FDA approved. And now the trick is, can we make it easier? Because it's really hard to do this therapy. First, you've got to take blood, filter out the T cells, ship it to a central manufacturing lab. That lab then takes those T cells, reprograms their antigen receptors to attack a target that is on the surface of your blood cancer cells, then stimulates the clone to grow, and then ships it back frozen, and it's infused into your body. Now, if it all works, those cells are immortal, and they will live there forever and continue to divide and attack the cancer. So that's cool. It can cost up to $500,000 per patient. So we'd sure like to get the price down. So Dr. Carl June at the University of Pennsylvania and his researchers turned to the idea of genetic molecules, in this case, RNA. So they created a kind of cancer vaccine that would carry instructions in RNA to make a protein that recognizes the B cells. And they packaged these into fatty capsules, which were B cells are another kind of immune cell, the kind that makes antibodies. They packaged these molecules into these nano lipoparticles. Then they coated them with a protein that the T cells would recognize and phagocytize. In other words, the T cells would would say, oh, I want some of that, and let it in. So that then gave those T cells, that RNA having gotten into the cytoplasm, then bounced off some ribosomes, and the ribosomes made the chimeric antigen receptor, which then saying, oh, I'm an antigen receptor, I belong out there on the surface of the T cell, and lo and behold, you've created these T cells. Now, this did the same thing, except the effect was only temporary, because RNA code only stays around in the T cells for about a week, given how our bodies are working, making this protein, and then you don't need any more, so you need to get rid of the blueprint. So we have RNA aces, which break down RNA floating around in the cytoplasm, and you reach this sort of dynamic balance between the production and the destruction of that RNA, which sort of keeps the whole thing running. So the researchers infused cancerous human beta cells and healthy human T cells into mice that had been bred to lack an immune system, so that they would not attack, their own immune system would not attack the foreign antigens. 1 week later, they injected the animals with 5 doses of these nanolipoparticles across about 2 weeks. Some got more than others. And 3 weeks later, they looked at the mice, and the mice who got the highest dose of mRNA had no detectable tumor cells. Now, they were as close as we could detect to being eliminated, says Dr. June. They also said, well, how dangerous is this? So then they used primates. They injected just the capsules with the mRNA, and this generated CAR T cells in the body that went after all beta cells. And so you could treat leukemia in primates, and one of the monkeys had a severe inflammatory reaction, but the other 21 monkeys actually did okay. So what the bad thing about this therapy, if it gets perfected for humans, is it's temporary. So further injections would be needed if the cancer returns, and the long-term effectiveness at least can't be known. The first person, the first human has been dosed in the last few weeks and is being watched. I don't know exactly how they're doing that study, but the point is, this is one of those things where we've got the tools, we're coming up with these crazy ideas of, well, let's try reprogramming this, let's try making something that blocks that. And a lot of them are actually turning out to be pretty darn good. So quite amazing, quite astonishing, and quite exciting. So we're going to talk about, well, do you remember the OJ trial? It was in the very, very beginning of genetic evidence. And basically the police departments didn't have very rigid protocols against contaminations. Contamination is a problem if you get insect DNA or other people's DNA in there. Fragmented samples can cause ambiguity in trying to read it. And in the case of the OJ trial and other types of genetic trial, what you're really looking at is genetic SNPs. You're looking at a sequence that's a standard human gene, but it's a little bit different. And then you look for the pattern of several variations. And statistically, if enough of the variations match, the probability that you're looking at a unrelated person to the culprit that you're chasing is very low. You could be looking at a family member. And in fact, that's happened. I'll tell you about that in a moment. But we want to differentiate. So we have these single nucleotide polymorphisms, which is where just one amino acid gets changed. And remember what I said about the protein feeding out of the ribosome as a string? Well, that string has electrical charges, positive and negative, on it. So as it folds out, it twists. And actually, it turns out there are proteins that cluster around it and make sure it twists in the right direction. Those are called chaperone proteins. All of this stuff that's going on is enormously complicated, and it's why we have these enormously complicated bodies and aren't just a mass of proliferating cancer cells. But you need fairly long segments for the SNPs because you need unambiguous evidence of a difference. there's another way of doing it. There's something called short tandem repeats of DNA. And this is where you've got you're going along, you've got your genetic code, and suddenly you'll see like a GAC, and you'll see that repeat maybe anywhere from 3 to 12 times. Those are called short tandem repeats. And they happen at certain locations, so we know where to look for them. It's very similar to in the process of gene replication. If you imagine when you're typing and you get distracted and you leave your finger on the keyboard and then you look back up at what you're typing and it's got like 16 A's and you're like, oh, okay, well, let's backspace. But that happens in the process of genetic transcription, and then once it happens, the system knows not to read those, so it just skips over them, those short repeats. But they're sort of like a unique genetic fingerprint. So the human genome can have many locations that have these stutters, or just a few. But if you look at the same 16 to 25 locations across, say, a group of individuals, the ones starting at number 12 and starting at number 3,460 and then starting at number 100,876, and you start there and look at how many repeats there are, you'll find a unique individual pattern such that the probability that two people that have the same number of repeats in the same 25 locations is vanishingly small. So we've got SNPs and we've got short-term repeats, and those technologies have existed for a while, and they've been used in crime. So when 23andMe came along and Ancestor.com came along, people started getting their DNA done. And DNA, most of it's conserved within individuals. You have these little single nucleotide variations, and those are used frequently if you run, and in fact, the Golden State Killer case is the most famous one in the United States, where they used DNA from a rape kit that was like a decade old, and they found a match. The match wasn't the killer. It was a relative of the killer. But then when they took a family history on this person, there was, I think it was a cousin who, they checked everybody out, and this person lived in the area and had been taken into custody on another matter, so they had their DNA. So they ran that, and bam, the SNPs matched, and they were able to nail the Golden State Killer. And that, I believe, that has actually gone to trial and been convicted. But that, something even more important, I think, for finding innocence is short fragments, little bits of DNA. And so the people there's an American company called Astrea Forensics that's spun out from the paleogenomics group. So let's talk about doing archaeology on DNA, right? That's paleogenomics. And, you're going at a site and you're scooping up stuff and you're looking for human DNA, and you're going to find probably DNA from more than one person in that cave. And you may have some animal DNA and some plant DNA, and you have to sort it all out. And that's been a real challenge. But researchers and the Astrea group they spun off as a company because they realized that they had something really special here, a technology that would look at the DNA found within hair. And the DNA, hair has long been considered too fragmented and too scarce to be of any use, but not any longer. Mitochondrial DNA, which is also in hair and is much easier to obtain than nuclear DNA, is very distinct. Now, you can't rule, that's shared broadly enough, but if you find that the mitochondrial DNA in a fragment doesn't match the person who's accused, they are automatically vindicated. If you are sure, you can look at their mitochondrial DNA that's not the person, and if you find other mitochondrial DNA that doesn't match your suspect, then, and you don't find the mitochondrial DNA of your suspect, you have to let them go. And in fact, this led to the release of a man who was living and had lived, his name's Charles Fain. He'd lived 17 years under a death sentence for raping a 9-year-old in 1982. And this new technology proved conclusively that the hair did not belong to him. And so then they took it through the fragmented nuclear DNA next generation sequencings for SNPs, which is this new technology that Astria is using. And they found a complete match from a guy who was already serving a sentence of 20 to life for kidnapping and sex crimes. So now, of course, another trial is happening for this one. But the point is, DNA analysis and backed up by forensic evidence. And one piece of evidence isn't enough to convict somebody, but it's enough to exonerate someone if there's a partial DNA match, but then the mitochondria don't match. And so that is going to probably let a lot of people out of jail. And it's probably going to let them go back to cold cases where they have a specimen, but they can't really analyze it. So work that was done in archaeology is now advancing law enforcement. And I just want to take a moment and pull out the soapbox, which I keep stashed under the desk here so that I can mount it on occasion, and say, okay, that research that got funded for paleoarchaeology is actually helping law enforcement find the perpetrators and avoid imprisoning the innocent. And that, my friends, is why you want to support basic science, because you never know where it's going to take you. And the basic science that of the space program had so many innovations that we use without thinking every day. Mylar, freeze-dried foods and coffees. Those are things that were developed for the space. Velcro. I mean, all of these things that are just part of everyday life that weren't around until the basic science needed to develop them. Oh, I shall shove the soapbox back under. Is endoscopy for Barrett's esophagitis going away? I sure hope so. And this one is ready for prime time. There's a new diagnostic method for Barrett's. It's brilliant. And again, new technologies, new materials, and new things can happen. Now, an endoscopy requires sedation, and so I don't like to recommend it in my older patients. You're gagging too much not to be knocked out to do it, and then you have to burn off the drugs that, can affect you when you're older. They can affect you for up to a week or two, and it's difficult to come back from that. In this case, you swallow a capsule with a string on it, and then drink some water, and it expands in your stomach. The capsule melts, what's inside the capsule expands, and it's a sponge. So those little tiny capsules, and you get the grandkids and you drop them in water, and they melt, and then they turn into a dinosaur that's like 2 inches tall, and everybody's all cool with how magic that is. Well, it's like that. It's a very compressed compound that expands in the stomach. Now you take that string and you drag it out. And as you drag it out, it rubs against the lining of the esophagus, essentially a kind of pap smear for the esophagus. And in this study, they were looking for high-grade dysplasia or cancer. So they did this in people before they had their endoscopy. And these were patients who had non-dysplastic Barrett's. I'll explain what Barrett's is now. And you know how you can get a callus on your feet if you walk around barefoot a lot? Well, Barrett's is effectively a callus on the esophagus. It's called squamous metaplasia. Now, normally, the lining of the esophagus is like the inside of your nose, not like the outside of your nose. But if it's burnt and roasted and irritated enough, the body says, no, we're going to change it into squamous cell. They start transcribing a different kind of epithelial DNA because, the third layer, the the epidermal layer is, the line. You've got the skin, you've got hair, you've got the nails. Those are all coming off of the same branch on the stem cells, but the lining of your nose and the conjunctiva on the inside of your eyelid and the stuff in your guts, that's coming off another branch. They're cousins, but they're different, and they're structurally different. One makes mucus, the other is very dry, for example. And when you get this change from the adeno to the squamous, you're causing a big shift in the DNA, and you get at the border where the change is happening a kind of confusion, a kind of disorder, and cancers like to pop up there. So when people have this squamous metaplasia, we have to go down there once a year and take a bunch of samples and look for dysplasia, similar to the old pap smear, where we would have to, this one's a little dysplastic, bring you back in 3 months, we'll do another pap smear. If it's dysplastic now and not just atypical, then we'll do a biopsy and we'll take a look at the path lab and see if we need to, remove the tissue around it, like you might remove a precancerous skin lesion. Well, in the case of that, you're doing this anesthesiology and this endoscopy, and it's a non-trivial procedure, and it does have its risk of complication. Better to do that than risk having an advanced cancer be discovered. We're not very good at fixing esophageal cancer, so we really focus on preventing it. But now they can look for glandular atypia and biomarkers like P53 abnormality. P53 is the programmed cell death. It's like, I've become abnormal, I need to kill myself for the good of the group gene. And the first thing that happens along the way to having a cancer is that P53 usually turns off. And of course, there's a lot of research going on to see if we turn that P53 back in and bring the cancer to its senses and get it to stop being a cancer. But, we've talked about cellular reprogramming, and I wouldn't rule anything out. But the positive predictive value for this, like if you had a positive atypia and an aberrant BNA, the relative risk of actually having a cancer on endoscopy was 100 times that of people who had a negative test. Now, that's the people who should get the endoscopy and get the biopsies, whereas the negative predictive value, and this is what makes it so important, is if you have people who get this sponge, get it pulled out, and it's analyzed, and there's no flags, there's no abnormality in no atypia, there's no P53. 98% of the time, that was correct. And when they got the endoscopy, nothing was found. So having a screening test that allows us to avoid endoscopy and target endoscopy on the individuals who actually need it is just amazing and could be a serious game changer in science. So we've got just a couple minutes. I'm going to talk to you a little bit about body mass index, BMI, versus body fat percentage. This study just came out. It was a cohort of U.S. adults in the National Health and Nutrition Examination Survey. And what they looked at was healthy adults and overweight or obese adults. Their cutoff for overweight was a BMI of 25 or above. They also looked at waist circumference, and cutoffs for waist circumference were 40 and 35, 40 for the men, 35 for the women. I'm going to emphasize those numbers are for Caucasians. The numbers are lower for people of Asian ancestry. And they looked at they went back and they looked at the 15-year mortality risk. And what they found was that the adjusted hazard ratio for having an overweight BMI for heart disease was 3.6. In other words, 3.6 more likelihood of heart disease. And for waist circumference, it was similar. It was 4 times. So if you had a waist above 40 in men, you had a 4 times adjusted heart rate, hazard risk for heart disease. And the body mass index, on the other hand, had no statistically significant relations with all-cause mortality. It's only good for calculating chemotherapy dosing. Otherwise, we should throw it over our shoulder, and everybody should get a bioimpedance analysis device. They can be obtained for under $1,000, and doctors should all have them in the office and be doing this routinely on physical. It's also good for a few other things, like calculating the amount of lean body mass and watching for the loss of muscle with aging. And I use that every year. My patients get checked, and if they're hospitalized for any period of time, I check them again, and we see how much muscle they've lost, and it's always more than we want. So that's when, when you're hospitalized, get fed and, have people bring you food. Have people bring you food you like. Have them sit there and kind of shame you into eating it. Keep eating if you possibly can. And even if you don't feel like it, try, because you're losing. If you don't eat, you're burning muscle. You're eating yourself. You can't stop eating.
Well, that's about all for this week's podcast. Please go to AskDrDawn.com for news about our future plans. For now, this is Dr. Dawn saying so long and stay healthy.
Ask Dr. Dawn is brought to you by Jiva Media. Production and editing by Charles Bansky. Music by John Scoville.